And begin, I think I see a chat. LPN together at Summersville School-Based Health for New River Health Association. And that was Teresa. So thank you so much for chatting that in. Robin, I can go ahead and share my screen if you're ready.
Okay.
Perfect. Thank you. Give me one moment. Can you see that okay?
Yes, I can.
Great. Thank you again.
All right, just any time now. I'll try to slow down this time. I know I usually fly through these, but this is a patient. She's 42 years old. She's been with me for several years, even through another couple of clinics that I've been at. Even before I started treating hepatitis, she's been with me. So she's been clean for about 8 years now. She is on Suboxone. So let me scroll down through. She's actually on her medicine list there. The Maverick, that's just from where we had put it through. We're set. She's not ever had treatment in the past. So she's immune to hepatitis A. She is immune to Hep B. You know, her height and weight, BMI 34.2. Down to her labs are relatively normal as far as her CBC. Normal. Creatinine is 0.67. The platelets were 124. INR's 1. Her, just gonna scroll on down. I know everybody can read those, but her APRI score was 2.944 and a MELD score of 6. She has an iron of 112, a ferritin of 1,020. Vitamin D is within normal range, but I think that I put her on vitamin D. Yes, she's on vitamin D supplementation. Her HIV is negative. She is genotype 3. Viral load 611,000 with a F0 fibrosis score. So this patient she's currently sexually active, and her partner, she's been with her partner for quite a while. And I have asked her to have him come in and be tested too, because I don't want to treat her and then them, you know, reinfect or him reinfect her. So he's actually going to come in too. She has 3 kids. You know, I think she's in a really good place in her life for this treatment. So what we were recommending for her would be the Maverick, 3 tablets daily for 8 weeks. So if there's any different suggestions, I'm glad to hear them.
Hey, Robin, this is John Gelfus. Quick question. Do you know how long ago she started using drugs? I'm trying to get a sense of her overall length of infection. So she stopped using about 8 years ago, but do you know how long?
Yeah, I'd have to call her back and ask her. You know, to be honest, Dr. Gelfus, I have so many hepatitis patients right now that I can't keep all that stuff fresh in my mind. I don't know that answer.
Totally valid. But my only worry on this lady is I think the fibrosis score could be incorrect. If she has, you know, we know she's been clean from using drugs for at least 8 years, and probably has acquired the virus sometime before then. And remember, this is genotype 3, so natural history is accelerated.
Right. I did see that. I'm not quite sure I understand the necrophilia activity score significance, because I do remember, she's pulling her labs for me right now, but I do remember hers was quite high on the necrophilia activity score.
It's a good question, and the necroinflammatory score gives you sort of a sense of the rapidity of progression towards more fibrosis, and it's A3. A3, okay. Yeah, and it sort of correlates probably very strongly with her transaminases, because her transaminases are quite high. The transaminases are sort of the poor man's activity grade. But, you know, her CBC, her AFP, and her ferritin all make me think that she probably has some more significant fibrosis. And that APRI score, so remember, when you see a platelet count in the low hundreds with somebody with chronic liver disease, it makes your antenna go up a little bit, that this could be a concern of somebody that is trending more towards cirrhosis. And why? Ultimately, it matters for two reasons. And one of which is obviously the long-term HCC screening. If you think this patient actually has a lot of fibrosis, you'll, even after curing them, want to follow them long-term. But more importantly, for regimen selection, this is one of these patients, if you remember genotype 3, if they're cirrhotic, you probably want to do resistance testing at baseline. And Kaylee can probably remember which the exact test is that what it's called, and I always forget the name of it, but it is, you want to do baseline resistance testing in the setting of genotype 3 and cirrhosis. And obviously we don't know this patient has cirrhosis, but there's a couple things out there that scare me. Just the ferritin, the AFP being a little bit high, and the platelet count being low. The APRI scores impressively high. And so, boy, you'd love an elastography on this patient. It'd be kind of cool to have a tiebreaker modality of assessing for genuine fibrosis score.
Okay, so what you're saying, the fibrosis score that you feel like was calculated from LabCorp was incorrect, that you think I should repeat some labs on that, or is it going to make a difference at this point?
I tend to always go with my most pessimistic prediction, and the APRI is giving you, it's really high. Your APRI is quite high, and it's suggesting that this isn't necessarily somebody that has no fibrosis. I would find it really hard to believe that they have no fibrosis, given that platelet count, that ferritin, that AFP, etc. Remember, these non-invasive biomarkers, none of them are perfect. And a lot of them demonstrate poor concordance with each other, where the APRI and elastography and the serum biomarkers may be all over the place. And the truth, you don't know which of them is the truth without the gold standard, which is a biopsy or some other imaging modality. But this patient would be a good one to definitely get imaging on to make sure you don't have grossly obvious cirrhotic morphology. You could just on an ultrasound or something, but therapeutically.
Ultrasound, do you want me to tell you what it showed?
Sure.
Hang on. We did that. Where was it at? It says, I'll just read the impression. Mild, non-uniform, diffuse, increased hepatic echo texture that suggests hepatic steatosis. No focal hepatic lesions or abnormal intrahepatic biliary ductal dilation. So everything was relatively unremarkable on the ultrasound.
Yeah, and remember the and thank you for getting that. That's very helpful. The what that's telling us is we don't have grossly obvious cirrhosis.
Okay.
And that's about the major conclusion I could take from that one. I would love to, there's room for opinion on this one. So certainly open it up to anyone else on the hub or elsewhere, if anyone else has any other thoughts on this one. Obviously, Epclusa, Mavorita are the only two options therapeutically.
I'll speak on that too a little bit, John, but yeah, Robin, I tag on to what Dr. Gilfus was saying, is that you want to err on the side of kind of the most pessimistic non-invasive measurement of fibrosis. And so if you have those discordant measurements, so her APRI is pretty high, and remember, all of these non-invasive tests, they do a much better job at ruling in advanced fibrosis than ruling it out. And that fibro test, really, even just to rule in disease, it's still only about 75% with a positive predictive value. So the fact that it's F0 would be nice if you had all the other measurements that agreed with it. So the APRI is high. Anything, remember, greater than 1, we get worried that there's, at minimum concern for advanced fibrosis, possibly cirrhosis. And then those other factors, like she's a genotype 3, she's potentially had this infection for some time to where that disease progression to her liver could have occurred. And so, you know, that imaging modality, and I didn't catch, what's her BMI? Is she overweight or obese or anything?
It's like 34, I think. Let me pull it back and look. Yeah, 34.
Her BMI is 34. So with any kind of like truncal obesity, even the elastography or ultrasound, that kind of imaging is not going to give you as good of a picture, since there's that fat tissue to get through. So, I mean, really, I would recommend an MRI of her liver in that scenario. Now, I know it's pretty reassuring with just the routine ultrasound that, you know, seems like she has some mild changes. So it could be fatty liver from the Hep C, from the being overweight. But, you know, I don't necessarily feel like you need to get an MRI before you start treatment, but I would recommend with the next screening. So in 6 months, you would want to do the hepatocellular surveillance screening for any liver lesions. And so I would just put down, you know, MRI as the next follow-up so that you get a good assessment of her liver contour. I also would recommend that because her AFP was a little bit elevated, which might just be from the Hep C, or it might be because she has liver disease. But anytime the AFP is more than 9, you know, you do want to make sure you get a good measurement, because sometimes an ultrasound can't detect really small liver lesions. So an MRI should be able to pick that up a little bit better. You could also repeat the AFP after treatment to see if it normalizes too. But yeah, since her platelets are low, she's got genotype 3. I would kind of consider her having advanced fibrosis until really proven otherwise. And then certainly counsel her on weight loss as well, since even once her Hep C is treated, she could still have that fatty liver disease or steatosis from, you know, high blood pressure, high cholesterol, being overweight, alcohol use, diabetes, all those things. So she needs to manage those conditions as well. And then the kind of only other things I would mention that we haven't discussed already is, you know, she's 42, but make sure you get a pregnancy screen unless she's fixed,
Yeah.
you know. Okay, so then you wouldn't need to worry about that. But yeah, just since there's no treatments approved. And then, yeah, you would have to get, so with genotype 3 and our patients that have cirrhosis, there is a much lower likelihood of achieving virologic response if you're using Epclusa and you have baseline resistance. So genotype 3 patients with cirrhosis are the ones that we do the NS5A polymorphism resistance testing on. And this is a really complicated test to order because nobody knows what it is. You usually have to call the lab and then, make sure that they know how to process that test. That's if you're using Epclusa. So if this patient already has baseline resistance and the mutation is called the Y93H, I think, then her chances of achieving sustained virologic response after treatment with Epclusa drop to less than 50%. So where we say, oh, Hep C treatment works so great, this is that one instance in treatment naive patients that are genotype 3, have cirrhosis, that we see that big gap in achieving sustained response. So if you're using Mavorite, the data doesn't show that. So their SVR rates are still very high. You don't have to do that specific test. But if you are using Epclusa and you have a genotype 3 with cirrhosis, do that baseline polymorphism testing. And I think she's on like a PPI anyway. So I mean, Mavorite, like you said, I would go with that one between those two. But that's the only kind of other teaching point I would bring up for the group.
Okay.
Any questions with that? Thanks so much for presenting her.
Yeah, thank you.
I appreciate it. Always do a great job.
Really tough case. Thanks, Robin.
Yeah, thank you.
Yeah, I agree. Thank you so much, Rob.
Yes, really appreciate the cases that you guys submit. So thank you so much for taking the time to do so. Are there any other questions or comments before we move on to the didactic portion? Dr. Feinberg did step away for a moment. So if I do have Jennifer Boyd had some questions for Kaylee, if that's okay, if we just take a moment, Dr. Feinberg, there you are. Is that okay if we just take a moment for some questions?
I just had to shut the window because you could hear the lawnmowers.
Oh, no, you're fine. Thank you. Go ahead, Jennifer, if that's okay.
Yeah, Dr. Feinberg, I just had a couple of quick questions for Kaylee in follow-up from, or anyone really, in follow-up from a case I presented back in March. Let me pull this guy's chart up.
Do you want me to just have the share screen capability for you, Jennifer? Are you okay?
No, I think I should probably just talk. And I think in the interest of time and in the interest of my brain, I'll, what I'm gonna do is just focus right on the questions without going back into the whole case. But, and if you need me to, I can pull him up. But when I presented him back in April, actually it was, we discussed the whole case. The plan was to start him on Mavorite. He's genotype 1A. He has no fibrosis, I think. I'm not sure I'm remembering that part right. But at any rate, we were waiting for him to have a second viral load 6 months from his first one, which I got in August, and it was positive. And so I'm getting ready to send in his prescription, but something strange happened when these are my questions. One is that when I tested him for hepatitis B in April, he had an isolated core antibody positive. For some reason, I repeated all of his hepatitis B labs in August when I did his hep C titer. And his surface antibody came back positive in August. So his antigen is negative. I didn't get a DNA. I think maybe I thought I had ordered the DNA, but at any rate, so now I've got one test that says he's surface antibody negative, one that says he's surface antibody positive. It doesn't seem like it would have converted after the core antibody. Should I repeat it, or should I just say that he's good? That's one of my questions. The other question, I'm reading it off some notes I made here, sorry. Oh, okay, I was wrong about his fibrosis. So when I presented his, and this relates to the case that we just discussed in a way, when I presented his FibroSure test that his fibrosis score was F1 to 2, but then since then he's had an elastography which shows fibrosis stage 3. And so his LFTs are still, they're not elevated. He is a drinker and he's really worked hard to cut back. He's still doing, as he says, 2 shots a day, which we've talked to him about, and his PCP really talks to him about it all the time. But at any rate, I figured that was okay still to proceed, but I just wanted to make sure, I wanted to make sure. So those are my questions.
Thanks, Jen. And I actually have your email pulled up too. I just suck at responding, but I was just looking back at the case. This is Kaylee. I
appreciate your help.
Yeah. No, I was pulling it up just in case there was anything else that you'd attached onto that. But a couple things. I mean, there's a few, I guess, questions I have first with his surface antibody. Was it quantitative or was it a qualitative? Did it give a number? It was just said positive. Oh shoot, I can't hear you.
Well, it's hard to hear me when I'm muted.
Well, I thought it was me because I'm sorry. So you said it was just
a trick I play on people sometimes. Hey, I think it's qualitative, but I'm going to look it up as we're speaking.
Okay, yeah. Just to see, kind of what the amount was. Is there any chance, any possibility that he could have been exposed to Hep B within the last year?
I don't think so. I didn't think of that, but I don't think so. He denied, when I did his initial intake, he denied IV drug use. I can't remember what we thought where the hepatitis C came from. Maybe a tattoo? I can't quite remember.
Gotcha.
Remember, Hep B from sex too. So.
Right. And I had asked him about that, and I don't think that was a risk factor. I'm sorry that I don't remember the original.
No worries. Is there any chance that you would have given him like a vaccination?
Oh, I didn't think of that. That might be the
And
answer.
maybe
Yeah, he might have
because
gotten.
we kind of touched on that concept at one point, kind of theoretically, you know, if they were isolated core, you could see if you could boost their immune response. So that might be a possibility. But what I would plan to do with him is, you know, I would, unless you had like a quantitative surface antibody that had good protection, so greater than, you know, 12, I would say would be the cutoff. I would go ahead and kind of assume that he's at risk for reactivation. And remember, you know, with the studies, it was really there was all that conflicting data. So it's really, if they're isolated core, it's still actually pretty rare for reactivation to occur. And so, you know, but kind of given he's also, you know, still drinking, his fibrosis has advanced so much, he's somebody that I would, you know, say he's definitely at risk for hepatic inflammation. And so I would go ahead and kind of monitor him with a DNA, Hep B DNA. And then also I would trend his liver enzymes and surface antigen while he's on treatment. You know, but he's not somebody that would necessarily need Hep B treatment or anything beforehand, but I would make sure and counsel him, you know, on signs and symptoms of Hep B flare reactivation, like the jaundice and acute hepatitis picture, just so he's aware of that, and definitely tell him, you know, you got to quit drinking, which I know you already are. His management wouldn't necessarily change with him being an F1 and then now an F3. You could still treat with Navarette and still do the same course. You could still do 8 weeks with him, but I would just really make sure, since he is still drinking, that you're counseling him on that risk of reactivation and or decompensation, because you got that alcohol component too.
Okay, that's really helpful. He did get one Hep B vaccine in February before we'd gotten his last back, and it was a qualitative, so that you were on target with all of that.
Gotcha. So that may have been, it might have just been that you know, he's had natural exposure to Hep B, but you gave him the vaccine and now it kind of boosted his immune response to it. So I wouldn't necessarily feel like he's going to be at high risk, but since it's not a quantitative count, then I would still just follow him as though he's at risk for reactivation. Thank you, though. Thank you so much. That's cool.
I should get that DNA before I start treatment too, though, don't you think?
I would go ahead. Like I said, he's you know, he's still considered, since his surface antigen's negative, he doesn't have active Hep B, but I would go ahead and just err on the side of, I'm pretty cautious about you know, the isolated core. Like I said, it's really low risk for reactivation with isolated core positives, but being that his fibrosis level has advanced and he's drinking also, I think it's most prudent to go ahead and get that baseline Hep B DNA. And then while he's on treatment, follow liver enzymes, follow his surface antigen. You can also consider checking, you know, a Hep B DNA during treatment, but typically you'd see the surface antigen and the liver enzymes flare up before, you know, that would kind of guide your Hep B treatment rather than just the DNA.
That's so helpful.
If
I
needed.
really appreciate the feedback.
Thank you so much. No, that's interesting. That was a good, I'm glad that you presented that. And I'm sorry I didn't respond earlier.
I completely understand. Thanks for everything you're doing to take care of COVID. It's just insane out there. So thanks.
Thank you so much. Thank you so much, Jennifer and Kaylee and everyone for your comments and suggestions. And know that you can submit a previous case if you ever want to, and maybe we could figure out some way that we could side by side them in the template so you guys can kind of see them. If it's a complicated case, we could always try and like configure that so that we can kind of look at what happened, even if something good, or, you know, you could see what happened out of treatment. That'd be great. All right, so we can move on, and remember to stick around for the poll after. We're going to move on now to Dr. Feinberg. I will go ahead and share my screen for you. Okay.
Okay. Oh,
Can you see that?
here we go.
You're good.
Are you going to do it or am I?
I can do it unless you want to.
No, I would prefer to actually. It's
Okay,
easy.
no worries.
Okay.
Let me get you all, you would prefer me to, or you?
No, I'd like to advance them.
Okay, let me make you co-host and you can go ahead and share that screen for me.
Okay, wait a second. So now. Now, why is it not? Hang on a second.
All right.
Why is it not showing me my? Oh, wait, I just clicked you. Uh-oh.
No, it's okay. You just click to view your entire screen, but you can pull up just the PowerPoint from there if you need to too.
Yeah. How come I am screen sharing? Okay. You know what? I did something strange here. I clicked on something and I see let's see, stop video. I see the
very top, you want me to
bar.
stop share?
No, yeah, I see. Let me see, stop share for a second. Okay.
There you go.
Now we're in better shape. Now I got you back. Like I had no picture. I don't know
Oh,
what
no.
happened. All right, now I can do, here it is. Sorry about that.
No, you're fine.
You know, you think after all this,
There it is. Beautiful.
after all this time. Okay, can you all see that?
Yes.
But it's not. Is it full screen for you or partial?
I can see it just fine, Dr. Feinberg.
Okay. So,
Perfect. Now we can see the state of West Virginia.
okay.
You're good.
So, you know, based on the Scott County, Indiana outbreak of 2014, 2016, I'm sure you're all aware that the CDC went ahead and did a risk assessment of the over 3,000 counties in this country. It came up with a list of 220 based on similar demographic characteristics to Scott County that were at high risk for a HIV and or Hep C outbreak. And here's the specific map for West Virginia. And we actually had the highest proportion of at-risk counties at 28 of our 55 counties. You can see with a pretty solid green blob there for central and southern West Virginia. So 51% of our counties, 13% of the total in the United States. And in fact, sadly, this has come to pass. And here is a map of West Virginia again. And what this is a map from the Bureau for Public Health. And what you see now is push pins for different outbreaks. And then the bottom third, the southern coal fields, are all in blue to indicate that these were the 15 counties involved in the southern counties cluster that was recognized in 2017. The Ohio County cluster up in Wheeling was a very small group of people, I think 5 people involved in prostitution. And then the really significant outbreaks here, the orange pushpin in Huntington for the Cabell County outbreak that happened in 2018, 2019. And then the most recent one here in Charleston, Kanawha County, that was first started in 2018 and is really a significant outbreak, ongoing outbreak. And of these 4 clusters, the CDC, the state asked the CDC to come in and do what they call an Epi-Aid investigation in the 3 largest, which were the southern coal fields, the Cabell County and the Kanawha County. And given that there's a limited period of time for me to present this, I'm not going to show you the data for the southern counties cluster or the Cabell County cluster, just because the most recent one is Kanawha, and I think there's sadly, a lot of good information about it. So in general, the number of new HIV diagnoses in West Virginia have been rising steadily for the last several years. So this was a slide I made earlier this year, and it was through the 2.5 years through the middle of 2020. And you can see in the right-hand column that not only is the total number of cases increasing, but the proportion associated with injection drug use went from 45% in 2018 to 68% for only the first half of 2020. Now, in a typical year, prior to this period, prior to 2018, the total number of new diagnoses that would be made in the state of West Virginia would be 77. The vast majority of them would be among men who have sex with men. So this signifies a real shift in the epidemiology and route of acquisition of HIV in our state. And in this next slide, I'll start to tell you specifically about this HIV outbreak in Charleston. So based on the 5-year average from 2013 to 2017, we'd have expected only 14 new diagnoses in the most populous city and the most populous county in the state. And fewer than 5 of them would have been in people who inject drugs. But in 2019, 6 new cases were seen in people who inject drugs. And this was unrelated to what was then the active outbreak in Huntington. And you can look up this Bureau for Public Health advisory that was published to alert people to this. And again, if you look at this 2.5-year period and compare Cabell County to Kanawha County, well, at that point, the total was 103 in Cabell, and 89% were associated with injection drug use, and 57, and now remember, this is only the middle of last year, and a little under half of them associated with injection drug use in Kanawha. And in fact, we are starting to see scattered cases around the state. So if you look at the 2 Ryan White clinics, the Ryan White Care Act is a federal with some state contribution to it, grant from HRSA that supports the care of people who are under or uninsured. And the 2 main clinics in the state are at WVU and at Charleston Area Medical Center. And you can see that in 2019 alone, almost a quarter of the new patients seen at our site here were associated with injection drug use, and at CAMC had gone up to 38%. So you can see that this climb is the outbreaks have been concentrated in and around Huntington and Charleston, but they really are scattered around the state. So the CDC was asked to come do an Epi-Aid, and what they found was between January 1st of 2019 and July 7th of this year, 72 new cases of HIV linked to injection drug use were identified in Kanawha County. And the CDC called this the most concerning outbreak in the United States. And below, I'm just reminding you that before 2019, there would have been fewer than 5 cases in Kanawha County that were associated with injection drug use. And this is actually a slide that Dr. Daskalakis from the CDC presented at Charleston at a meeting of the Charleston City Council and the Board of Health on February 11th of this year. And out of the over 3,000 counties in this country, only 4 had more HIV diagnoses among people who inject drugs. Now, the national data is only, at this point in the year, was only complete for 2019. So they only found 4 counties that had more PWID cases in 2019 than Kanawha had in 2020. And 3 of these counties had an average population of greater than 4 million. So these were big, big cities. And the 4th was Cabell County. So you can see that West Virginia's high on the list here. And then if you look at it the other way around, if you look at US counties that have a population size similar to that of Kanawha County, the average number of new HIV diagnoses among people who inject drugs in 2019 was less than 1. So clearly bad things are happening here in Kanawha County. So of the 72 people that were diagnosed in the outbreak window, which they defined as January 1st, 2019 to the end of June of this year, they were able to in this Epi-Aid compile medical histories for 90% of these individuals. And really fewer than a third of those who were identified as HIV positive had received any care related to their HIV in the previous 3 months. And they did a molecular analysis of the viruses, and they found 3 distinct clusters that could be defined from the molecular structure of the virus, the genetic structure of the virus, and the data they had indicated that there was really rapid transmission of these clusters. And in fact, one cluster had a transmission rate that was 12-fold higher than the national average. So remember, I should have said this in my introduction, the syringe service program, let me stop and remind you that the syringe service program in Charleston, which opened in December of 2015 and was the 3rd syringe service program in the state, became really very active, and within a year or so had served over 6,000 people from 192 separate zip codes, many of them from the southern counties. So people were driving up to Charleston, getting these syringes and supplies, and driving back home to Welch and Princeton and Beckley and Pineville and the other southern counties where there had already been a smaller problem identified. In March of 2018, so before this outbreak, the city of Charleston closed that syringe services program. So there was no longer any real way for people to get sterile syringes, clean injection supplies, or rapid testing for HIV and Hep C. So the CDC Epi-Aid said, given the evidence of ongoing rapid transmission, response activities should be approached with urgency. I mean, this is a tough thing to say about a city and a county that had already closed its syringe services program. And then after the state legislature passed Senate Bill 334, which drastically restricted how syringe service programs could operate in West Virginia, the politicians in Kanawha County decided that they would make this even more stringent. And in addition to civil penalties, they added jail time for anybody caught giving out sterile syringes. So, and here, this is happening in the midst of this outbreak. And I think it defines for you sometimes that our politics are not well aligned with our public health needs. So I'm going to show you now in the next few slides what some of the results of this Epi-Aid. So when they looked into the risk factors of these 90% of people that they could compile a history for, they found that the majority, 61%, had ever at some point been either homeless or unstably housed, couch surfing, whatever. Almost a third had ever been incarcerated, and more than a third had been diagnosed at some point with a mental health condition. So that's kind of the background for this group of people. And of course, the most important and ongoing risk was that 3/4 of these individuals were injecting drugs within 6 months of their last healthcare encounter. They looked at healthcare utilization of these 60 individuals and found a total of 498 encounters across, a range of healthcare agencies, anywhere from EMS to, inpatient hospital stays, and found that there was a median of 5 total visits per person, that the majority, 42%, were in the emergency department. And in the next slide, specifically 212 of those 498 encounters, so a little less than half, happened before their HIV diagnosis. So more than half of these encounters happened after people were diagnosed with HIV infection. And here you can see now that these prior to diagnosis encounters, the vast majority were in the emergency department, right? 60% were in the emergency department, 27% were hospitalizations, and only a very small percent were in healthcare encounters that happened in the outpatient arena. And here's the kinds of diagnoses that were made. And you can see that even though this is a group of people for whom you would expect drug intoxication and overdose to be common elements, collectively, they only accounted for 6% of the diagnosis before they had a diagnosis of HIV. But half, 51%, were infectious. That were infectious manifestations, of which the vast majority were skin and soft tissue, right? Abscesses, cellulitis, etc. But a quarter of them were diagnosed with sepsis. And then you can see specific diagnoses for endocarditis and osteomyelitis that are bloodborne, typically bacterial infections. And really only 1%, only 3 individuals were seen for a sexually transmitted infection. Across these 212 encounters that happened before a diagnosis of HIV, only 5 HIV tests, negative tests, were recorded. So despite the fact that people are coming in with track marks, right, with skin and soft tissue infections, it being utterly clear that these are people who inject drugs, there was not enough attention paid for them even to be screened for HIV. And not a single person was prescribed pre-exposure prophylaxis. Not a single person. All right. So there you go. Not really an adequate reaction to the clinical situation. So there were 5 primary recommendations from the CDC Epi-Aid report. These were just released in last month in August. So this is all very new. Well, the first one was almost silly in the context of Senate Bill 334, which was to expand access to sterile syringes and other injection equipment through comprehensive harm reduction services such as low barrier one-stop shop models in multiple locations that also incorporate mobile and street outreach elements. And I will tell you that none of this conforms to the new law and the regulations that are being promulgated, to put the law into practice, right? This recommendation, I think, is falling on pretty deaf ears, at least at a legislative level in this state. The second one was to increase opportunities for HIV testing through routine opt-out screening in medical settings. And I put this in bold because this is something all of you can do, right? And I'll come back to that in another slide or two. They recommended that we integrate HIV treatment and prevention services with other services already being used by at-risk populations, that we increase communication and community engagement around the disease and interventions for the disease, and use data around service needs for people who inject drugs to help detect and respond to HIV transmission. And, the sad thing is that our public health workforce in West Virginia is very limited in size. County health departments had their budgets cut considerably about 7-8 years ago, and only a small proportion of those budgets have been restored. And they are all quite overwhelmed now with the COVID pandemic. So, we've got, multiple epidemics happening at the same time in a public health system that is, under-resourced, undermanned, and totally overworked, which is a shame. So this is something from a rally that SOAR, let's see, that stands for Solution-Oriented Addiction Response, which is a group of people in Charleston that had been operating syringe services, but, fell afoul of all of these new laws. And it says HIV SOS, and I think that's a very appropriate message. It is an SOS here. So we have, just conclude by saying that we have a really urgent need to prevent and respond to HIV in this state. We are now the national hotspot for HIV. I know this seems incredible because HIV has been sort of a very, West Virginia has been a very low prevalence, low incidence, kind of low risk state for HIV. I don't think it's ever been, you know, a big deal in terms of publicity and public awareness. I think people who inject drugs do not see themselves at risk. I think many people who inject drugs don't even know that there are these outbreaks happening, not, you know, around the state. And of course, we need to counter this from a public health perspective. We need less restrictive and needs-based, non-punitive syringe service program models. But Senate Bill 334, it just totally runs afoul of this. And that's a shame because many syringe service programs really provided screening, offered rapid screening for HIV and hepatitis, as well as linkage to care. And the programs that realize that they're not going to meet these new criteria have already closed in many locations around the state. So if you visualize the map of West Virginia, there is now not a syringe service program between Morgantown and Huntington. And if you visualize the state of West Virginia, you will see that is a very, very big chunk of geography. So I think it's ever more important, just as, you know, Hep C ECHO is trying to get primary care providers to take care of, you know, our Hep C epidemic. I think we need you to provide HIV screening and HIV PrEP, pre-exposure prophylaxis, and whether that's sexual and or injection drug use risk. Because the only way we're going to end the epidemic in this state is by actively screening, providing PrEP, and then effective treatment of people with HIV. And you may not be aware, but we've got a number of phrases in the HIV world. Treatment is prevention, because it's been shown that in a discordant couple where one has HIV and the other does not, if the person with HIV has an undetectable viral load, they do not transmit HIV to their partner, even when they're practicing unprotected, condomless sex, unprotected sex. And that is an amazing and wonderful outcome of the really good medicine that we've developed for HIV. Unfortunately, unlike Hep C, even though it's also an RNA virus, it has eluded our attempts, including a very recent study, just this past week, that was negative, a vaccine study, where we still don't have a really good way to, other than PrEP, a really good way to prevent HIV, and we certainly haven't yet cured HIV. But we really need to do this. We really need everybody to be thinking about this. Now, of course, as part of your Hep C workup, you are looking for HIV. But there's all those patients you see who aren't coming to you for their Hep C, and they need to be screened too. So my last couple of slides really focus on how you can increase screening for HIV, especially in rural areas. So opt-out screening is a situation where you offer an HIV testing as part of routine care. You no longer need written informed consent in West Virginia for HIV care. When people sign the consent just to receive care in general, they are consenting to whatever blood tests you order for them. And my favorite way of saying this, and I put it on the slide, is, you know, here's what I'm going to do today. I'm going to check your blood counts, your kidney and liver function, your cholesterol and other lipids, your thyroid, HIV and hepatitis status, et cetera, et cetera, et cetera. Like, it's just another test, as opposed to focusing on the HIV and making people uncomfortable, because nobody likes talking about sex. or at least not in a healthcare setting. People don't like to talk about sex. Patients don't like to talk about it, and providers don't like to talk about it, and everybody is uncomfortable. And really, even though I did HIV care and research for 3-4 decades, it took me a while to get to the point where I could just really talk about sex like it was just another everyday thing, and to say to people, do you have sex with men, women, or both? Right? It took a while for me to get to that point. So, but this is what you have to practice saying to people, and where HIV is just another part of well person care. And again, you do not need specific written consent, right? But you got to practice what you preach. You have to screen everyone. If you wind up through some instinct of your own or some bias of your own, picking and choosing whom you offer an HIV test, then you're going to miss people, because none of us are good enough to know who really has HIV, right? We don't have electron microscopic eyes. We can't see the virus. And we don't really know what everybody does in the most private parts of their life. So you really have to screen everyone. And an easy way to do this is to talk to your administration and get your EMR to get programmed for routine lab order set, which you may already have, for your new patient visits or your annual patient checkups. And now these things should include a 4th generation HIV test, and should include a hepatitis C antibody with reflex to RNA PCR. And if this is really routine and it's painless for you, right? You just hit the box that says new patient labs or annual patient checkup. I mean, that's what you need. You need that support from your administration to make it easy. You also need to ensure that all the staff in your practice setting are knowledgeable and supportive of opt-out screening. If you say it in this totally bland and reasonable way, and then the patient goes to the phlebotomist and the phlebotomist starts saying, "Did you agree to an HIV test?" Like, it's just not going to work. So you have to get everybody in your office on board. And hopefully you've already made great strides with that, because you're treating hepatitis C, and that comes with a lot of bias and stigma too, right? Around the bias and stigma around injection drug use. So, hopefully you've already got staff who are just going to be reasonable about this, but you need to ensure that, because you've got to address this stigma. Both HIV and substance use disorder carry tremendous stigma, and both you and your staff, need to be mindful of this. And you need to also really, whenever you have the opportunity to address your community, you really need to communicate the need for screening, for PrEP, and for rapid initiation of treatment for people who test positive to HIV. Because the other big phrase we have, in addition to treatment as prevention, is we have undetectable equals untransmittable, or U equals U. And this is what I said before. If you have HIV and it's well controlled by medication, you are not a risk to other people. You are not a risk to other people. And hopefully that will begin to, counter all the misinformation that people have and the bias that people have about this. And I think that should be my last slide. So happy to take any questions, but I hope I've convinced you, just as you've already been convinced that you need to screen for Hep C, you got to screen for HIV here at West Virginia. And you, our primary care workforce, you are the answer to this problem. Not like the 5 HIV docs here at WVU. We are not the answer, because we're only here in Morgantown. So this is a really important, I hope you absorb this and take it up and make it part of your mission, right along with Hep C. And let me answer any questions you might have.
Thank you so much, Dr. Feinberg. I think it'd be hard to step away not wanting to do that after that presentation. And I do think it's a great topic to discuss. And I will say, like in the past, I was happy that I was negative, but I was happy that actually my primary care physician mentioned a test. But I was really curious to why they ask, is it okay if we give you a blood test for HIV to see if it's there? This is years ago, but I was really confused of why they would ask. I just was assuming they would just do it, I guess. But yeah, I think it should just be so normal, like just kind of, why wouldn't you want to know, you know?
You know, no. You know, studies have shown even before this test became, you no longer needed to have specific written consent. Studies showed from the old days that people assumed that when they went to see their doctor and got their annual physical and had all those tubes of blood, people just assumed they were being tested for HIV. And when no one afterwards called them and said, you know, you have HIV, they just assumed they'd been tested and were negative. So now is our chance to actually make that a reality, is to really ensure that everybody gets tested and to just do it across the board. You will never be able to identify. I mean, I've been doing HIV care for 4 decades, and I can't tell you by looking at people or even talking to them that they do or don't have HIV. There's just no substitute for that blood test.
Thank you. I
did
did have one question pop in the chat. And does rapid transmission have to do with the distinct molecular cluster or with needle sharing, sex, and person's behavior?
So when they do this molecular analysis and look at how similar the virus is, you know, these are RNA viruses, they morph over time. They morph in the same individual and between individuals. Like if you give your HIV or Hep C to person number 2 and they give it to person number 3, there's changes that you can track over time from persons 1 to 2 to 3. So when they look at the molecular structure of things, they can see if there haven't been very many changes, genetic changes, that means that transmission is really rapid. The assumption is in these individuals who have not had access to a syringe services program since March of 2018, that it is very likely to be due to injection drug use, that people who inject drugs have sex too. So, and also some of them, have transactional sex, trading sex for drugs or money or, other desired outcomes or goods, that, you can't say for sure that it's only from injection drug use. But given that, all of these individuals in this, this 72-person outbreak were people who injected drugs, the assumption is that's the way it happened. But you can't, there's no way to prove that.
Perfect. Thank you so much. We are at time. I do apologize, but please, if you have any questions, reach out to me and I can reach out to Dr. Feinberg. It was a wonderful presentation. I'm just going to throw the poll up and just the one announcement that our next session will be September 23rd with Rachel Mitchell discussing drug interactions. So be sure to be here if you can.